Okay, so next we have is acute inflammation. See, enough neuro for a day. Okay, just come. Let's complete this general part, this thing, because we have already done parts of medicine, neuroanatomy, okay, and some parts of neuropathology as well, and neuroembryology. Okay, so I think that is enough neuro for a day, because today on schedule there was gynae also, and ma'am schedule, and I was following that as well. Okay, let's see. Acute inflammation. The only thing is here edema, transient, characterized neutrophils, edema, seconds to minutes, minutes to days, innately not very much important. Okay, the mediators are a bit. So arachidonic acid, toll-like receptors, eosinophils, neutrophils, Hageman factor, that is factor 12. Okay, Hageman factor is factor 12. Okay, because they can give the name Hageman. Okay, Hageman is 12. So Hageman is 12. Hageman 12. Okay, arachidonic acid metabolites. Then inflammasome, what is it? Cytoplasmic protein complexes recognizes dead cells, microproduct system activated by interleukin 1 inflammasome. Okay, all this is not, this is this TGF beta. Okay, so vascular vasodilation, obviously you have those components. Array extravasation of leukocytes from postcapillary, all that is fine. 4 steps, margination, rolling, we just see it now, transmigration, chemoattraction, and so on. Protein leukocyte post-cap, but the protein leukocyte, they basically come out from which part is the post-capillary venules. Post-capillary venules, that's where it is coming out from, post-capillary venules. So this part is not that important. Outcomes. So healing is interleukin 10 is healing. Okay, interleukin 10 is for healing because it is anti-inflammatory. Interleukin 10 is anti-inflammatory. TGF beta, okay, that is also anti-inflammatory. So these are like healing. When you say healing, then these two are for healing. TGF beta and interleukin 10. TGF beta, interleukin 10 is healing. Persistent acute inflammation, interleukin 8. Okay, persistent acute inflammation, interleukin 8. Abscesses, ठीक है, this is fine. Fibrosis, antigen presentation by macrophages for chronic inflammation, CD4 TH. So we had 1 and 8, that is T helper 1 was 8, CD8. Okay, and that side CD4 was T helper 2, because we have to make the multiple of 4 2s are 8. We'll see it in immunology. Macrophages predominate in the late stages of acute inflammation, peak 2 to 3 days after the onset. 2 to 3 days after, macrophages will come, cytokines will be secreted. Healing is interleukin 10, TGF beta, interleukin 8 was acute inflammation, persistent acute inflammation. Okay, very important page. Okay, match the following, and this has come time and again, all of it, anything can come from this. So post capillary venules, very important. All this extravasation occurs in the post capillary venules, so I guess really don't need to keep this here. Okay, obviously it's going to be post capillary venules from where everything is coming out. Okay, let's see. Margination rolling, leukocyte adhesion. All right. Okay, so margination rolling, E-selectin, interleukin 1, TNF alpha upregulates, P-selectin released Weibel Palade bodies, glycam and CD34. Okay, so these are the this thing mediators. And leukocytes pe what are, so vasculature, on vasculature in stoma what is present, on leukocytes what is present. So first is margination, then is rolling, then after it is tight binding adhesion, then diabetes, then migration. Okay, so margination and rolling, you have E-selectin upregulated by TNF and interleukin 1, P-selectin released from Weibel Palade bodies, glycam 1, CD34. This side E selectin, with E selectin we have sialyl Lewis, P selectin we have sialyl Lewis, and L selectin we have. So L stands for leukocyte, leukocyte selectin. E stands for nothing. Okay, just PL stands for, remember, L is going to be leukocyte, P is going to be Weibel Palade bodies, CD34 glycan. Okay, defect, if there is defect, leukocyte adhesion deficiency type 2. Leukocyte adhesion deficiency type 2 is margination rolling, and adhesion is a more stronger, say, tighter bond, so that's why type 1. Okay, leukocyte adhesion type 1, decrease CD18 integrin subunit, decrease CD18 integrin subunit, that is. Okay, so decrease sialyl Lewis, that means leukocyte issue. Decrease CD18, that means leukocyte issue, because in the CD80, CD11 and CD18 integrins present on leukocytes, LFA, MAC, LFA1, MAC1, VLA4 integrin, VLA4 integrin. This is something that needs to be seen in the last day as well. Next, vasculature stroma, we have ICAM CD54 and VCAM CD106. Still, I do not have any this thing for it. Okay, okay, I mean, no mnemonics. Diapedesis, transmigration. Here we have PCAM. So first was ICAM, VCAM. Here is PCAM. Okay, transmigration, CD31. Again PCAM, CD31. PCAM1, PCAM1, same. Okay, migration. For migration we have C5A. Okay, C5A, very important. This is A. Okay, usually mix up. C5A, interleukin 8 was persistent inflammation, LTB4, calcicril platelet activating factor, and formal methionine peptides. Okay, next let's go back and see this. So margination and rolling, E-selectin, these are sialyl Lewis proteins, sialyl Lewis. Okay, margination rolling, type 2 leukocyte adhesion deficiency, adhesion and binding, type 1 leukocyte adhesion deficiency. So LFA ICAM, this is LFA ICAM. LFA is on CD18. What is it here? We have to go back and see CD18. Okay, ICAM. Next is transmigration going down, and finally this. Okay, PCAM. CD18, yeah, CD18 issue. So again, leukocyte will see sialyl Lewis, L selectin, CD18, 11, LFA, MAC1, V4, PCAM, various. Okay, done. Let's go ahead. Okay, quickly. Obviously, chronic macrophage infiltration, mononuclear infiltration, then persistent infection, trypanosome type 4 hypersensitivity, chronic inflammation, trypanosome TB, all this, there's type 4 hypersensitivity, autoimmune reaction, toxic agents like silica and foreign body material. T helper 2, interferon A gamma. Okay, macrophages dominant. Okay, interaction macrophage and T lymphocytes. T helper 1 gamma secretes, T helper 1 secretes interferon gamma, macrophage classical activation. Okay, T helper 1 secretes this is actually well given in pixarized. T helper 1 and T helper 2, interleukin 4, interleukin 13, macrophage alternative activation. This is quite I mean, it may not look very this thing, but it's quite volatile types. So yeah, okay. So T helper 1, interferon gamma, macrophage classical activation, T helper 2, interleukin 4, interleukin 13, alternative activation. Classical way you'll become pro-inflammatory, alternative way they'll be repair and anti-inflammatory. Okay, interleukin 4 was also, it is not only secreted T helper 2, okay, it is also interleukin 5 versus interleukin 5 also. Okay, means it causes interleukin 5 secretion also. Okay, outcome scarring, neoplastic transformation, HCV, hepatocellular carcinoma is an example, gastric adenocarcinoma, helicobacter pylori, cardiac gastritis is an example. Okay, next, wound healing. Okay, okay. FGF, so wound healing tissue mediators. Okay, so the main thing is here in this table, TGF beta most important. Okay, TGF beta most important. Okay, so TGF beta it's anti-inflammatory, tissue regeneration it helps in. TGF beta is in tissue regeneration, anti-inflammatory, and TGF beta inhibits metalloproteinases, decreases extracellular matrix degradation, angiogenesis, fibrosis, increases synthesis of collagen fibronectin. Okay, collagen fibronectin. So these are wound healing mediators. TGF beta is anti-inflammatory. We saw no TGF beta and interleukin 10. FGF is your angiogenesis. Fibroblast growth factor. Okay, VEGF is vascular endothelial disease. So this angiogenesis नाम से can derive it from the name itself, VEGF. PDGF is a bit distinct, platelet derived growth factor. Obviously, it is going to be coming with the platelets. Macrophage, vascular remodeling, smooth muscle cell migration, vascular remodeling. Obviously, everything to do with the vascular. Stimulus cellular growth factor for collagen synthesis, metalloproteinases, tissue remodeling, and that's it. EGF. Okay, endothelial growth factor basically stimulus cell growth by tyrosine kinase enzymes. Okay, so tyrosine kinase ERB1. ERB1. Main thing is TGF beta. Okay, and what are the ones that is in angiogenesis? To PDGF, VEGF, FGF, TGF beta, all this angiogenesis. Okay, so and especially this TGF beta. Okay, next is this. Okay, wound healing and phases of wound healing. Okay, so phases of wound healing. First, obviously, first you'll be having. I mean, this I'm reading after a long time, so let's see. Inflammatory 3 days. Okay, you have inflammatory phase, neutrophil, macrophages, and so on. Day 0 में clot formation you're gonna have. Okay, so 3 days is inflammatory phase. You have clot formation at day 0. Increase जैसे वो 48 hours of peak. Within 2 days, 48 hours peak, you have neutrophils that migrates. Okay, neutrophils migration C5A. Okay, C5A cytotoxin C5A, and macrophages comes in the day 3 and clears debris on day 2. Just a second. Okay, so there, so clot formation, all that is done. Okay, we got clot formation, we got increased vessel permeability, neutrophil migration, done. Proliferative phases, day 3 weeks, fibroblasts, day 3 to 5 granulation tissue. Okay, week 1 and 2 collagen 3, 3 collagen 3. Okay, collagen 3, try recollect. Collagen 3 also Ehlers-Danlos syndrome. Okay, collagen 3 related to Ehlers-Danlos syndrome also, and collagen 4 is all the basement membrane diseases. Example: Alport syndrome, then Goodpasture syndrome, all that is collagen 4. And collagen 3 was what? Ehlers-Danlos. Week 1 and 2 angiogenesis. So come back to this proliferative day 3. Just remember day 3 collagen 3. Okay, so that is easy. Day 3 collagen 3. Okay, and there day 3 tak you have inflammatory. And this is going to be day 3. Okay, day 3 you have 3. Collagen 3, angiogenesis, epithelial cell proliferation, so on. Wound contraction, day 3. Dissolution of clot mediated by myocytes, delayed second phase of wound healing. If you have delayed second phase of wound healing, that is collagen issues, it's all vitamin C, copper deficiency. or it can also be maybe Ehlers-Danlos. Okay, collagen 3 was Ehlers-Danlos only, because I remember E ka 3 this thing. So vitamin C, copper deficiency, second phase of wound healing issues, important. Day 3, indirect questions can come. Remodeling 1 week to 6 plus months. Remodeling, fibroblast. Type 3 collagen replaced by type 1. Type 1, that was bone, tendon, all that. Cartilage is 2, type 2 collagen. So type 3 collagen replaced by type 1 collagen increased enzyme and tissue. Collagen is zinc requires breakdown. Collagenesis requires zinc deficiency. Delayed wound healing. So here we had vitamin C and copper. Vitamin C and copper is second phase, okay, that is proliferative phase, and zinc deficiency is remodeling phase, okay. So this is important. Zinc deficiency, remodeling. Vitamin C, copper deficiency, proliferative. Next we have 30 minutes to 4 hours leukocyte margination. Mast cells, they lose the granules and so on. Okay, like this is just a, see, this 30 minutes to 4 hours is a part of this part. This is a part of this. Okay, that is 3 days. 30 minutes, 4 hours, leukocyte margination. Mast cells, they lose the kind of fibrin. Okay, next 4 hours done. 4 hours is polymorph infiltration and all this epithelial regeneration starts. And 12 to 24 hours, you have this mononuclear infiltration beginning. So very simple. Type 3 collagen 3, type 1 collagen comes in the 1 week of remodeling. Zinc deficiency, vitamin C, copper. Macrophages, all this clot formation. Done. Okay. Granulomatous inflammation. Okay. So granulomatous inflammation mainly in TB, and type T, it is a T cell response walled off and persistent inflammation. Who was in persistent? Interleukin 8 was in persistent inflammation. Interleukin 10 and TGF beta were the healers. Focused epithelioid. Okay. So focused, what is that cell? Focused epithelial cell activated macrophages, abundant pig cytoplasm. Basically, epithelial cells are what? Activated macrophages with abundant pink cytoplasm. What is it? Activated macrophages with abundant pink cytoplasm is epithelioid cells surrounded by lymphocytes and multinucleate giant cells, that is fusion of several macrophages. So epithelioid cells is activated macrophages with pink cytoplasm, abundant pink cytoplasm. This is surrounded by lymphocytes. This is also important in Ashraw's bodies, caterpillar cells, and so on. Caseating necrosis, central necrosis. Okay, caseating is associated with central necrosis seen in infectious etiology. TB fungal non-caseating is no central necrosis. Caseating, central necrosis. Non-caseating, no central necrosis. Non-caseating adenoma examples are sarcoidosis, Crohn's. Non-infectious, autoimmune, non-caseating. Non-infectious, autoimmune, non-caseating. Sarcoidosis, Crohn's. And that's it. Caseating is all the infectious. TB, fungal aspergilloma. ठीक है, fungal. Next is mechanism. Okay, so APC presents to T helper 4. APC T helper 4, and this has helper 4 has MHC2 complex. Helper 4 has what? MHC2 complex. 4 to the 8. That secretes interleukin 12. Okay, interleukin 12. That in turn, so CD plus differentiated T helper 1. Interleukin 12 means this itself is acting on itself. Okay, T helper cell, CD4 plus cell Antigen presenting secretes interleukin 12. Interleukin 12 converts CD4 helper differentiates to T helper 1 cell. T helper 1 secretes IFN gamma. IFN gamma macrophage activation. IFN gamma is macrophage activation. Macrophage increases cytokine secretion, formation of epithelial macrophages and giant cells. Anti-TNF therapy. Sequestering granulomas can break down sequestering granulomas and cause disseminated disease. So this is dangerous. Anti-TNF therapy, because TNF is responsible for the granuloma formation. If anti-TNF is given, then sequestering granuloma is breakdown and will cause disseminated disease. So that's why it's important. Latent TB. Test for latent TB before starting anti-TNF therapy. Test for latent TB before starting. Interesting point. Very interesting point. Associated with hypercalcemia, increased alpha hydroxide activated macrophages resulting in increased vitamin D activity. Okay, hypercalcemia due to increased 1 alpha hydroxylase activity. 1 alpha hydroxylase activity. So this was it. APC antigen, interleukin 12, T helper 1 is activated. Okay, then after that, this thing T helper 1 activates itself after antigen presentation. Then we have interferon gamma being secreted, macrophage activation secretes TNF alpha. We have to take care of TNF alpha, and this is going to be lymphocytes, fibroblast, and all this surrounding cells. Granuloma structure is important. Next, etiologies. Okay, so like when you'll have this granulomatous inflammation, very important. Mycobacter tuber, Bartonella, Hensley, cat scratch disease. Starry sky appearance, stellate necrotizing granuloma, that's why you have starry sky appearance. Listeria monocytogenes granuloma infantiseptica. Listeria famous for causing meningitis in children, pregnant ladies, baby with this thing, Streponemoplasm tertiary syphilis, endemic mycosis, histoplasmosis, and schistosomiasis. Immune mediated sarcoidosis, non-infectious granuloma is going to be sarcoidosis, Crohn's disease. Subacute D. querulans granuloma, that's thyroiditis, this will come across. Okay. Next, primary biliary cholangitis. Primary biliary cholangitis, granulomatous with polyangiitis, eosinophilic granulomatous with polyangiitis, temporal arteritis, Takayasu, Fernberg berylliosis, talcosis, and chronic granulomatous disease. So all that is this thing. Next is scar formation. Scar formation, 70 to 80% of the tensile strength, non-regenerated cells, secondary, 70 to 80% tensile in 1 week, 10%. Okay, in 1 week, 10% is gained, 70 to 80% tensile strength is gained in 3 months. Excess TGF beta. Okay, TGF beta was healing. Okay, anti-inflammatory. So, hypertrophic versus keloid. Okay. Hypertrophic, see, keloid is haphazard. Okay, that's why it's disorganized. Increase both 3 as well as 1. Next, this is 3 organized, confined. This is not confined, keloid. And originating claw-like upper extremities. Infrequent. Keloid is very recurrent. This is seen also increased incidence in dark-skinned people. Now, another very this thing. Okay, yeah, this is fine. Just the collagen number is important. 3 and 1 and 3. 3 and 1 and 3, and there we had the proliferative phase where first it was 3 and then after it we had 1. In case of chronic inflammation, the collagen, this thing. Next we come to neoplasia. Very, very, very important. Okay, so these definitions not very significant, just go through it. Very simple, and we'll go very quick. Uncontrolled, obviously, non-neoplastic proliferation, all this is fine. Normal cells with basal, normal cells with basal to apical polarity. Normal cells basal to apical polarity, loss of uniform dysplasia is obviously loss of pleomorphism in clinical hair, carcinoma and tissue, irreversible, severe dysplasia, entire thickness does not penetrate, and this obviously penetrates, so you can see this is normal. This is mild dysplasia, has become weird, more weird, and this is completely severe dysplasia, carcinoma and situ still hasn't come this thing. Next is theonomenclature important. Carcinoma, sarcoma, benign, well differentiated, malignant erratic gotosis, non-neoplastic hamartoma. This is important. Disorganized growth. What is hamartoma? We get that hamartoma ka picture also. Okay, which always people get confused. I also get confused with tubular villus polyp, hamartomatous polyp with Pew-Jagger syndrome. Hamartomata Hamartoma is disorganized overgrowth of tissues in the native location. Native location. Okay, disorganized growth in the native location is hamartoma. Pew-Jagger's polyps, cori Corystoma also called corystoma is in a foreign location, while hamartoma is the native location. Hamartoma native, corystoma foreign. Gastric tissue, distal ileum, Meckel's diverticulum. Okay. Example: corystoma, Meckel's diverticulum. Hamartoma is Pew-Jagger's. This adenoma papilloma, adenocarcinoma, gastric adenocarcinoma, most common, H. pylori. Okay, next is no H. pylori. No. This is, I think, Barrett's. Next is, well, this is fine. Hemangioma, not very important. Liver small, melanoma. Melanoma, remember, I think it was 2 centimeters growth. Okay. Next, differentiation. Anaplasia. Anaplasia, complete lack of differentiation in a malignant neoplasm. That is anaplasia. Differentiation, all this important. Grade, and this grade is basically cell mitotic activity. Okay, cellular differentiation, mitotic activity. Cellular differentiation, mitotic activity. That is grade. Okay, low grade, well differentiated, and stage is how, where has it gone. Okay, spread is stage. Size and primary lesion, pathologic findings, prognostic value. More prognostic value is the stage. Okay, stage has more prognostic value. Stage determines survival. S for stage, S for spread, S for survival, S prognostic value. Okay, TNM stage. Okay, and that one is mitotic activity. Next is hallmarks of cancer. This is like the most this thing. Cancer, all this DNA, all this proto-oncogenes increase factor. Okay, proto-oncogenes increase autokine loop, PDGF in brain tumors. Okay, growth factor constituting a HER2 HER2 is a growth signaling. Okay, signaling molecules. HER2 is very famous in breast cancer, and growth signaling molecules like RAS, transcription factors like MEC, and cell regulatory like CDKs. Okay, these are all this thing. So brain tumors was platelet derived growth factor. All healing tissue. Anti-signal growth factor, obviously insensitivity, tumor suppressor genes, gone, loss of E-cadherin function, especially E-cadherin is in gastric cancers, contact inhibition, NF2 mutations. Evasion of apoptosis, TP53, BCL2 follicular lymphoma. Okay, follicular lymphoma again was what, 1418, BCL2, and backs, those were pro apoptotic. Okay, SMART diablo. Okay, we had read in the morning. Limited replicative procedure, reactivation of telomere, tumorigenesis and aging, lengthening. Okay, also there's something called Hayflick's limit, so 50 to something, that also just go and see. That is then BTR. Sustained angiogenesis, VEGF, leaky capillaries dilated, all this fine. Tissue invasion, loss of E-cadherin function, Okay, metalloproteinate degrade based on the ECM, laminin, fibronectin. Not very this thing. Next, tumor cells. Tumor cells adhesion, cytometastasis, fine. Warburg effect is important. Shift of glucose metabolism away from the mitochondrial oxidative phase towards glycolysis. Warburg's effect is basically from mitochondrial it's going to glycolysis. Glycolysis rapidly provides the dividing cells with the need, whatever cellular structures is needed. Next is immune evasion in cancer cells. Tumor cells secrete TGF beta. It was anti-inflammatory. Recruit regulatory T cells. Okay. Decrease MHC class 1 expression by the tumor cells. Cytotoxic T cells unable to originate class 1. CD8. Class 1. CD8. Okay. Next, tumor cells regulate immune checkpoint. Okay, immune checkpoint. This is PDLA, PDNL, and all that. Against all those, we have that nivolumab, pembrolizumab, and all that. Okay. Next is this immune checkpoint inhibitor is most important. Okay. If possible, I'll do immunology also. Okay, if I don't feel sleepy, that is. And again, tomorrow in the morning, I'll do neuro. Just the remaining parts. Few remaining parts are there. Okay. Immune checkpoint inhibitors. This is like here's where we go like really slow. Okay. Oh god, again the honking is come. Just a second. Okay, forget it. Okay, honking hoga. Immune checkpoint interaction signals that modulate T cell activation and function. Fine, decreased immune response against the tumor cells. Okay, so decreased immune against the tumor cells. Several cancer immunotherapies. Interaction now. See, this PD1 and PDL1 and L2. This interacts, right? So, immune cells, and this is a dysfunction. So, what happens is this is APC antigen presenting cells and this is the T cells. Okay, so T cells way you have PD1 and on APC you have some this PDL L1 L2. Okay, the PDL1 L2 on this. Alright, and microenvironment, all this is done. Now T cell dysfunction or exhaustion. T cell dysfunction or exhaustion. T cell dysfunction exhaustion. Because when this APC interacts with this, it causes T cell dysfunction and exhaustion, inhibited by antibodies against. So, what happens? This interacts. When these two interact, it causes T cell exhaustion and dysfunction. Okay. It is inhibited by antibodies against PD1 and PDL1. Okay. PD1 के against हुआ था antibodies in green. These three. Semiplimab, nivolumab, pembrolizumab. Okay. Okay. Now, one thing, Pembroli was used in endometrial carcinoma. This is a previous year question, very recent previous year question. Don't forget, Pembroli is the endometrial carcinoma and melanoma. Pembroli is the endometrial carcinoma, melanoma, microsatellite instability, and mismatch repair deficiency defect. Basically, that's what it corrects. And Semipilimab, nivolumab, and pembrolizumab. All of these are what? PD1. PD1. Again, come back and see. This is like last moment stuff. PDL, PD1, PD1. Semiplimab, nivolumab, pembrolizumab. Semiplimab, nivolumab, pembrolizumab. semiplimab, nivolumab, and pembrolizumab. And this one PD-L1L2, atezolizumab, durvalumab, and avelumab. Atezolizumab, durvalumab, avelumab. And this, okay, CTLA4. Okay, so we have CTLA4, basically B7 on the APC, and it interacts with CD28. Okay, when it interacts with CD28, then only you get this proper signaling. But CTLA4 is the competitor. Okay, so inhibiting CTLA4 helps in interaction of this. So that's why MHC2 can interact with this T helper cell better. So that's why we have something to destroy the CTLA4 competitor, that is ipilimumab. Okay, now I have a mnemonic for this. Although we'll come to it later again, I'll just recollect it here itself. Ipilimumab, ipili is pili. Okay, so everything that is pili in the body is going to use ipilimumab. So RCC, renal cell carcinoma, because urine is pili. Then hepatocellular carcinoma, because liver is pili. Okay, next is colorectal cancer, because your shit basically is pili. Okay, so colorectal carcinoma. So all is ipilimumab. Next is atezolizumab. Durvalumab is Durlab. Okay, so Lab is lung cancer, urothelial cancer, and B was bladder cancer. Okay, Nivolumab, I forgot this one. Okay, and Pembroli is the endometrial carcinoma and melanoma, and there are others also. So when it will again come in the drugs, then again we'll study that. I mean, I'll take out the mnemonic that time. Okay, negative. Actually, I think I'll take out the mnemonic and say it aloud only. So, ipili and all this to be this thing. I'll just take out the mnemonic once. Give me a second. Okay, so everything is done. Yeah, correlate with India. Okay, this is the skin basic most common cancer in males here is prostate. In India, I think it was this thing, smoking. So lung, colon, rectum. This is like cancer mortality, lung, prostate, carcinoma here. Females is breast, lung, colorectal. And this colon cancer mortality rate. And children is on leukemia. CNS and neuroblastoma. Okay. So, yeah, before we can go, just let's quickly. These are the MCQ IDs, okay? Where the pass to your question is there. So, anyways, whatever. And 2018 का Nobel Prize was this negative immune cell regulation treatment of carcinoma. This was the Nobel Prize it was given. Okay, forget it. Okay, so the mnemonic for this these checkpoint inhibitors. Okay, the first thing though, it's going to be basically what are the immune checkpoint inhibitors, the names. Okay, so naye purane dost, dur at CIA. Okay, so credit goes to DAMS ka one of the faculties, Dr. Dinesh Yadav sir. And we have nivolumab, pembrolizumab, dostanozumab, durvalumab, atezolizumab, semiplimab, ipilimumab, and avelumab. All right. So that is it. नए पुराने दोस्त दूर at CIA. Okay, नए पुराने दोस्त दूर at CIA. CIA is CIA. Okay, at is this atezolizumab, दूर and नए पुराने दोस्त पुराने. Okay, and dostanumab also you can add. Okay, so ipili is going to be pila rang MLC. Okay, so ipili is pila rang MLC. So basically you don't even have to remember MLC, just remember pila rang. Okay, rang से lung, Rang से rang and lung matches, no? So pila is what? It is a rang. It is a color. Rang means color in Hindi. So rang and lung it rhymes. So that's why it is lung. This rang and lung I made, okay, and pila one also I made. So this is like this thing. So like credit, mnemonic or credit, I'm giving it to the faculties. So Pila, HCC, and this thing, RCC, and your colorectal carcinoma, and finally add melanoma and lung. Okay. Next, even high resolution CT also you can use like as a mnemonic, HR lung CT. Okay, but that is okay, fine. नेक्स्ट निवोलुमैब. कम टू निवोलुमैब. निवोलुमैब क्या क्या है? लंबे घूंघट में हेड. लंबे घूंघट में हेड. सो लंबे इज लंग हाइडर. ओके, घूंघट इज GI. जस्ट इमेजिन समवन पुटिंग द घूंघट टिल द स्टमक. ओके, सो लंबे घूंघट में हेड. सो लंबे इज लंग, लिवर. घूंघट इज GIT. में melanoma and mesothelioma. Okay, everything for lung is coming here in nivolumab, and H is head and neck cancer and Hodgkin's also. Okay, and durvalumab is durlab. So that I had said only lung, urothelial and bladder. And atezolizumab is big bull. Okay, so big bull is basically bull is breast, urothelial, liver and melanoma. Okay, melanoma ke liye lots of things I used. Okay, so I think this is more than enough. Okay. Okay, so lots of questions from this one. Obviously, breast was blastic and this thing both. Okay, and and blastic, I think mainly blastic is prostate. See, mixed is breast, lytic is thyroid and non-cell. Okay, thyroid and non-cell, thyroid, kidney and non-cell is lytic. Blastic is prostate and small cell. So non-small cell is lytic and small cell is blastic. Small cell is blastic. SB. Okay, SB protein na, SB protein that was present in DNA. Okay, so small cell prostate, BPS. I don't know what this thing. Okay, small cell prostate, blastic, breast mixed, lytic is thyroid, kidney and non-small cell. Predilection for axial. Okay, mainly. So bone, there's mainly predilection for axial. You have prostate mainly from prostate. Next is breast, kidney, thyroid, lung. Okay, painful bones kill the lungs. Painful bones kill the lungs. Axial skeletal and bone metastasis. The primary bone metastasis is more than the primary tumor itself, and multiple myeloma is most common. Liver, say you have cancer sometimes penetrates liver. Cancer sometimes penetrates liver. Okay, basically that is the mnemonic. Colon, stomach, pancreas, liver, lung mets most common sites after the regional lymph node. Okay, like liver is the most common site of metastasis after this thing, and you have colon cancer, stomach cancer, pancreas. Okay, next is brain, lung, breast, melanoma, colon, kidney. Lots of brain mets can kill. Lots of brain mets can kill. Okay, kind of, but see, this is not that much required to learn. Main thing is this. Okay, this is the most important. And here just liver ka colon you can remember, bone ka prostate you can remember. Okay, and brain ka lung you can remember. The first ones, LCP. 50% of the brain mets obviously comes from metastasis, just like the bones. Multiple vessels, right? This is important. Okay, because they'll give you a CT. I mean, they'll give an MRI. ग्रे वाइट मैटर, CT MRI दे देंगे. ओके, CT ही देंगे. नहीं, CT नहीं, MRI they'll give, MRI. Okay, this grey white matter junction. Okay, they can give MRI, they can give CT, anything. Grey white matter junction means mainly you'll find it at grey white matter junction. Okay, When it is a metastasis, then the lesion will be gray white matter junction. See this B, okay, gray white matter junction. You can see this, and this is the liver, and then this is the bone mets F. Okay, E and F is all the bone mets, and D is what? Liver mets. C and D is liver mets. G is what? G is going to be the axial skeleton. Okay, so I think we're more than done. Next, this I just can't stress the importance of this table. This is supposed to be revised in the last moment as well, and this one also. Okay, so consecutively 3 pages of lots of good information, 4 pages. Okay, so 5 pages, literally 5 pages of super useful information, and then we'll stop this video. Okay, so very important, very important. Okay, 5 pages of the most hiled and basically needs to get this thing in the last, like, last few days. This needs like last day itself. गाड़ी में जाते जाते revise this. Okay, revise the genes. Okay, so let's start. First we have this. Okay, this was in one of the pleomorphic adenoma, HMGA2 plag 2. Okay, oncogenes, these are all the oncogenes. Okay, and PDGF is glioma leukemia. PDGF is glioma leukemia. Oncogenes, they undergo point mutation, promoter insertion, amplification, and enhancer insertion. All these are the changes from proto-oncogenes to genes. That's what makes them increase in cancer risk. Okay, so proto-onco, one allele ka damage is required. Now let's go ahead and see. HMGA2 plag 2 pleomorphic adenoma, PDGF glioma leukemia, ALK, ALK, so ALK receptor tyrosine kinase, lung adenocarcinoma, HER2/neu, we know. Okay, ALK is something like, let's mark the forget it. ALK can this thing, HER2/neu everyone knows, ERBB2, breast and gastric carcinoma, RET is meant to A, meant to B, this is also known. Okay, medullary papillary thyroid carcinoma, pheochromocytoma, BCR-ABL also. Your CML-ALL. BCR-ABL is CML-ALL. Okay. This का Daltons, कितना kilo Daltons, that is also one significant, will come to it in hematology. BCR-ABL, CML-ALL, BCR-ABL, CML-ALL, JAK2 myeloproliferative neoplasms, JAK2 myeloproliferative BRAF. Okay, this can be this thing, JAK2 myeloproliferative neoplasms, BRAF is melanoma, non-Hodgkin's, colorectal, papillary, hairy cell. Okay, next is c-kit. C-kit is just mastocytis, mainly just is important. C-kit just c-MYC Burkitt's, already all this has come. MYC-L1, L-MYC gene, L-MYC or MYC-L1 is lung. Okay, so L stands for lung. Okay, this is also this thing. Small cell carcinoma. Okay, and MYC-CN, okay, NMYC, that is NMYC is neuroblastoma. Okay, 1P. KRAS colorectal RAS CTPS, and pancreatic cancers, papillary follicular Hürther cell carcinoma, thyroid. KRAS. Okay, once more we'll do it tomorrow again. BCL2 anti-apoptotic inhibits apoptosis. B-cell lymphoma, follicular. BCL2 is basically BCL2, B-cell lymphoma. Okay, this is more or less. So ALK is lung, HER2/neu breast, and gastric also can be. RET is all the thyroid, medullary, papillary, MEN2A, MEN2B, pheochromocytoma. Okay. Also, medullary thyroid, where was it? Medullary thyroid, I think it was in meant to be. Okay, you had marfanoid habitals also in one of the men's. Parathyroid issues also in one of the men's. Red rat. Okay. BCR, ABL, CML and ALL. CML, ALL. Kamal. This is like Kamal. We can just BCL hai Kamal. Okay. Kamal. Okay. Kamal. Like if we had to make a mnemonic here, this is basically BCL Kamal or whatever. Okay. So JAK2 myeloproliferator, BRAF, this has to be BRAF, melanoma, non-Hodgkin's, colorectal, papillary, hairy cell, c-kit, GIST, can be remembered, c-MEC, Burkitt's, MIC-L1, L-MIC gene, lung cancer, small cell, MIC-N, N-MIC, neuroblastoma, TEF, and tetralogy, tracheoesophageal fistula, and KRAS, and we have follicular primary hurdle cell. Okay, fine. Next set. So this is Knudsen two-hit hypothesis is required. Okay. Also, this thing is also important. Which chromosome we can red is present in chromosome number 10. MIC N is present in 1P. Okay. So let's read it only very fast. And read it again and again every day for the next few days until 5th November. Next, tumor suppressor, APC gene, colorectal cancer, APC beta catenin WNT pathway, negative regulator 5q chromosome. Okay, done. Next is BRCA, BRCA1, BRCA2, 70q, 17q, 13q. BRCA1 is on 17q, this is on 13q. BRCA, breast ovary prostate pancreas, breast ovary prostate pancreas. CDKN2A, P16 blocks G1S phase. Okay, P16 blocks G1S phase. Many cancers, melanoma, lung. DCC is deleted colorectal cancer. Okay, fine. Colorectal cancer, SMAD D4 is DPC4, deleted pancreatic cancer. Pancreatic cancer is colorectal cancer. Pancreatic cancer, colorectal cancer, MEN1, MEN, multiple endocrine neoplasia, MEN gene. Next is NF1. NF1 is going to be neurofibromin. Neurofibromin RAS GTPase activating protein. NF1, NF2. 17q is NF1, 22q is NF2. Merlin-Schwannoman protein, and that is NF2. Okay, so neurofibromin RAS GTPase activating Merlin-Schwannoman protein is NF2. NF2, NF1. P10. P10 is P13K AKT pathway, prostate, breast, endometrial cancers. P10. This is a NEET important. Okay, BRCA 1 and 2 is also NEET. Men is INI, RB is INI, TPH is INI, WT1 is INI. 13q14 is RB1, inhibits E2F, blocks G1 to S phase, obviously G1 to S phase. TP53 also blocks G1 to S phase. E2F, retinoblastoma, osteosarcoma, okay, retinopathy, pinealoblastoma, TP53, P53 activates P21 DNA. Carcinogen of the leaf from any. Okay, Sabla syndrome, Sabla Nari. Sarcoma, breast leukemia, adrenal. Sarcoma, breast leukemia, adrenal. Leave from any may we had this thing. We had all those cancers. I mean adrenal cancer, and there was osteosarcoma, I think, and yeah, TSC1 is harmatin protein. I'll just check out leave from any once, okay, because it is an important piece of information. Okay, just a second. Leave from any, I'll tell you what all it had. Leave from any adrenal osteosarcoma. There was adrenal osteosarcoma, and osteosarcoma nahi. Okay, there were bone cancers. Okay, there was bone cancers, but most importantly, there's adrenal cancer, sarcoma, breast cancer, and sarcoma. Okay, sarcoma, breast, your bone, and adrenal, and this is supposed to be tumor suppressor, and it is an autosomal dominant on chromosome number 17. Autosomal dominant chromosome number 17, adrenal cancer. Okay, next is TP53, Sabla syndrome. Okay, basically Sabla, leave from anywhere you have Sabla, sarcoma, breast leukemia, adrenal. Okay, and bone cancers also. TSC1, TSC2, tuberin, tuberous sclerosis. Okay, tuberous sclerosis. Tuberous sclerosis we're going to do tomorrow also. TSC1, TSC2. One is on chromosome number 16 and another one is on, you have to see. VHL is von Hippel-Lindau, inhibits hypoxia inducible 1A, inhibits hypoxia inducible 1A, and WT1, that is united development of transcription factors. Wilms tumor, WT1, WT, okay, WT, Wilms tumor, okay. Wilms tumor, if I had to recollect something about Wilms tumor and nephroblastoma, it we have to differentiate it from neuroblastoma. You have rosettes, certain rosettes that you have to see, small blue cells, I think carcinoma, Wilms tumor. Okay, next is Notch1, loss of function, chromosome number 9q34.3. Not really required, but yeah, like chromosome numbers are not really required, but you, the name and this thing. Okay, tuberous sclerosis, we'll come across this tomorrow. Tuberous sclerosis. There was mitral valve issues. There was, what else in tuberous sclerosis? You have those leaf, this thing. Okay, something leaf. Wait, tuberous sclerosis. Okay, then there was uh, something renal angiomyolipoma. Then tumor suppressor gene, variable expression, autosomal dominant, Harmartin gene is chromosome number 9. And angiofibroma, regurgitation, shagreen patches. Yes, ash leaf and shagreen. Ash leaf, shagreen, cardiac rhabdomyoma, and hamartomas. So I guess we did it today also. Tomorrow also we'll be doing it in neuropathology. Comparatively easier. Next is carcinogens. Asbestos. First, let's do quickly the ones that has come. So aflatoxin. Anyways, let's do sequentially only. Aflatoxin, aspergillus, toad, green and nuts, liver, hepatocellular carcinoma, aflatoxin. Alkylating agents, oncology, leukemia, lymphoma. Aromatic amines, benzidine, 2-naphthyline, arylamines, aniline dye. Okay, this is tobacco, 2-naphthylamine, bladder cancer, transitional cell. Okay, so bladder and blood, very important. Bladder and blood. See, benzene, epoxide, occupational exposure causes EML. Benzene causes AML, but here your aniline dies, that is benzidine. Benzidine causes bladder cancer. It is benzidine. Aniline dye, benzidine, aromatic amine, 2-naphthylamine. Tobacco smoke, cyclophosphamide, irradiation, all this textile industries, bladder cancer. Benzidine, arylamine, benzidine, that is bladder. But benzene is AML. Benzene is AML. Okay, benzene is AML. Benzidine is bladder cancer. Okay, arsenic herbicide, vineyard workers, metal smelting, wood, skin, arsenic skin. Okay, vineyard workers, shipyard, I think, mesothelioma, lung cancer, squamous cell, hepatic angiosarcoma. As oh no, arsenic is not mesothelioma. It is asbestos that is mesothelioma. Arsenic is hepatoangiosarcoma, lung carcinoma, squamous cell carcinoma, and that is skin. While asbestos is roofing material, shipyard, lung, esophageal, gastric, colon, bronchogenic carcinoma more than mesothelioma. Tobacco smoke, bladder cancer, transitional cell, most important. Rest is related to almost all the organs. Ethanol, esophagus, esophageal cancer, liver cancer, breast cancer. Ionizing radiation, thyroid papillary thyroid carcinoma, samoma bodies, orphan ani nucleus, leukemias. Okay, and you have that dystrophic calcification also. Or it was metastatic calcification, I think. Nickel, chromium, oropharyngeal cancer, beryllium silica. Okay, oropharyngeal carcinoma, nickel causes oropharyngeal carcinoma, nickel oropharyngeal carcinoma, nickel, chromium, beryllium, silica, lung cancer, occupational exposure, radon, lung cancer, nitrosamines present in smoke, food, stomach cancer, gastric cancer, intestinal type, vinyl chloride, PVC pipes, liver, hepatic angiosarcoma. Angiosarcoma was also being caused by arsenic. Okay, benzene, occupational exposure, AML, benzidine is bladder cancer, cadmium, prostate. Okay, cadmium, prostate cancer. This is the MCQ ID. You can see it, MC5868. Next, oncogenic microbes and the associated cancers. Nothing to be missed out from these pages, last few pages of neoplasia. Epstein-Barr DNA virus, CD21, Burkitt cell, Hodgkin's lymphoma, NHL, nasopharyngeal carcinoma, primary CNL, DLBCL. Okay, especially Burkitt's is important. Next, all this is pro-virus mechanism. Okay, DNA virus again, HPV, hepatocellular carcinoma, lymphoplasmacytic lymphoma, HHV is Kaposi, HPV cervical 16-18, penile anal head and neck cancer. Okay, obviously that head and neck cancer, we had it for HPV head and neck cancer. Which one? Laryngeal carcinoma. Next is H. pylori, not laryngeal carcinoma, papilloma. Okay. Next is H. pylori, gastric adenocarcinoma, malt, adenocarcinoma, malt. H. pylori, adenocarcinoma, not anything else. Adenocarcinoma is H. pylori. HTLV, flavivirus, HCV, that is HTLV1, that is RNA virus, hepatitis C, flavivirus indirect. All this causes adult T cell leukemia, lymphoma. Liver fluke, Cornorchis sinensis, cholangiocarcinoma, schistosomia hematobium, squamous cell of bladder. HIV, Burkitt, DLBCL. Okay, Kaposi was what? HHV8. Serum tumor markers for diagnosis and screening, very important. Alkaline phosphatase is bone liver. ALP is liver specially, basically alkaline phosphatase. And GGT, exclude hepatic origin by checking for GGT levels liver. So you have the biliary duct, that is GGP. ALP is also usually biliary duct. Seminoma is ALP. Seminoma placental ALP. This then give. Okay, because they love the gynae tumors and gynae tumor markers. ALP, seminoma, placental ALP. Seminoma, placental ALP, alpha fetoprotein, hepatocellular carcinoma, endodermal sinus tumor, that is yolk sac. Okay, yolk sac, mixed cell yolk sac, and other name for yolk sac, endodermal sinus tumor. Very important, very very important. Don't this thing. Yolk sac is also called yolk sac tumor, is also called endodermal sinus tumor. Ataxia telangiectasia, neural tube defects, alpha fetoprotein. Where did we see? Yes, yesterday, anencephaly and this thing in anencephaly and spina bifida. You don't even need this, you can rub this out because we saw it in anencephaly, but it there was no changes. It was normal in spina bifida, I think. Okay, so that level we have to see. Again, acetylcholinesterase was also increased in case of amniotic fluid. Okay, normally midwifery transient eliminated in pregnancy, high volume, neural tube defects, Down syndrome. Low levels in Downs, very important. Okay, high level in neural and abdominal wall defects. So even abdominal wall defects, it is high level. Even abdominal wall defects, it is high level. But the most important is low levels, that is associated with these low levels, they are associated with Down syndrome. So it is associated with Downs. Downs is important. Alpha fetoprotein down में down. Alpha fetoprotein down में down. HCG, hydatiform mole, choriocarcinoma, gestation, trophoblastic tumor, all this is important. Testicular cancer. Mixed germ cell synthesized by syncytial trophoblast, syncytial trophoblast, syncytial. Okay, this is important. This entire thing is important. Next is C15, 3, CA 27, 29, breast cancer, CA 1990, 1990, 99 is pancreatic adenocarcinoma, CA 125 ovary, calcitonin, medullary thyroid. Papillary thyroid ka markup is what? Calcitonin, medullary thyroid, we read before also in calcification. Metastatic calcification. And calcitonin is then meant to A, meant to be also. Why? Parathyroid, I think. Or thyroid carcinoma. No, meant to A and meant to be both have medullary thyroid carcinoma. That's why. So calcitonin. Calcitonin is medullary thyroid carcinoma marker. Meant to. Okay, meant to. So calcitonin. That's why it's meant to and medullary. Alright. CEA colorectal carcinoma. CEA colorectal carcinoma, carcinoma embryonic antigen. And minors, it's also in associated when colorectal carcinoma is associated with liver metastasis, then CA is increased. Pancreatic cancer, gastric, breast, medullary thyroid. Chromogranin, neuroendocrine tumors. Chromogranin, neuroendocrine tumors. LDH, testicular germ cell tumor, ovarian, dysgerminoma, other cancer. Can be used as an indicator of tumor burden. Okay, LDH is testicular germ cell tumor. LDH, testicular germ cell tumor, dysgerminoma, alpha fetoprotein was what? Okay, alpha fetoprotein was endodermal sinus tumor, and this LDH is dysgerminoma. Very important, very very important. Testicular germ cell tumor is also important. Neuron specific enolase, neuroendocrine tumor. Small cell, very important. Small cell carcinoma, neuroblastoma. Okay. PSA, prostate specific antigen, gastrin. Okay, this is not necessary. Gastrin, PSA. Okay, PSA, gastrin. Gastrin is going to be pancreatic net. This has come previously. Gastric is pancreatic net. Gastric. Gastrin is present in pancreatic neuroendocrine tumor. Neuron specific enolase, all this to be did. LDH dysgerminoma, alpha fetoprotein endodermal sinus tumor or yolk sac tumor. Seminoma, ALP. These are very, very important. Dysgerminoma. Okay. So this dysgerminoma, LDH, alpha fetoprotein, ALP, all the gynae cancers. ALP seminoma. Okay. ALP seminoma, LDH dysgerminoma, alpha fetoprotein endodermal sinus tumor. Next is very important. S100 we had seen. Just a second. Now I'm already feeling sleepy. Okay, anyways, just let's push it through, finish neoplasia and be done with it. Lymphoma, common leukocyte antigen. Lymphoma, common leukocyte antigen. Primary site of origin, metastasis, metastatic tumors. This is an immunohistochemistry staining. Okay. For lymphoma, we do common leukocyte antigen test. MYC2 Ewings. MYC2 is Ewings. Chromogranin synaptophysin, neuroendocrine cells. Chromogranin synaptophysin, this was their neuro. Small cell carcinoma of lung, carcinoid, neuroblastoma. Okay. Small cell carcinoma, we did have. Carcinoid tumor, we do have. And neuroblastoma. This causes what? Pellagra like symptoms. Pellagra, was it that? You have to see. Cytokeratin epithelial cells, squamous cell carcinoma, desmin is muscle actin, leiomyoma, GFAP, neuroglia, Schwann cells, oligodendrocytes, GFAP, okay, neuroglia, Schwann cells, oligodendrocytes, astrocytoma, and glioblastoma multiforme. Neurofilament neurons, PSA, prostate specific antigen, S100 is neural crest cell, melanoma, Schwann cell, Langerhans cell, histiocytosis, and NET, PNET. Okay, TRAP is tartrate resistance. TRAP is also now tartrate resistant acid phosphatase, hairy cell leukemia, vimentin mesenchymal tissue, fibroblast endothelial cells, macrophages, sarcoma, calretinin. Calretinin is mesothelioma. Calretinin is a common leukocyte antigen, CD45, lymphoma, CD45 lymphoma, P glycoprotein. This is general pharma stuff. Inducer is rifampin, CD243. So rifampin is the inducer, ATP dependent efflux pump. Okay, multi-drug resistant protein 1, ABC transporter, ABC transporter. Classically, adrenocortical carcinoma. Adrenocortical carcinoma, colon or liver, used to pump out the chemotherapeutic agents. Some more bodies important. Papillary thyroid somatostatinoma, adrenal calcifying fibrous pseudotumor, meningioma, mesothelioma, ovarian serous carcinoma, prolactin and prolactinoma, and serous endometrial carcinoma. Again, we have to go back and see this dystrophic calcification, not metastatic calcification. Highly dystrophic calcification. Dystrophic. Okay. Metastatic was all the. Go back and see. TNF alpha, interferon gamma, interleukin 1, interleukin 6. Cachexia is caused by TNF alpha, interferon gamma 1 and 6. Okay, 1 and 6. Paraneoplastic syndrome. This is dermatomyositis, Godwin's papule. We did have heliotrope rare. They always give the picture. Adenocarcinoma, ovaries. Acanthosis nigrans, velvety plaques. Gastric adenocarcinoma, visceral malignancies. Sign of lesser trilat. GI adenocarcinoma, sudden onset multiple seborrheic keratosis, hypertrophic osteoarthropathy, clubbing, adenocarcinoma of lung, arthralgia, joint effusion, periostosis, and PTHRP. This is important. PTHRP mimics, okay, squamous cell of carcinoma of lung, head, renal, ovarian, bladder, ACTH, ADH, lots of stuff, lots of endocrine stuff in small cell carcinoma. Squamous cell में is PTHRP. This is the most significant. Squamous you'll get PTHRP, but rest everything is present in small. Okay, ACTH, ADH, increase ACTH, increase ADH, increase 125 OH2, vitamin D3, calcitriol. Polycythemia is erythropoietin, increase pheochromocytoma, renal cell carcinoma, HCC, leiomyoma, hemangioblastoma, pure aplasia, decreased low reticulocytes, thymoma, hypogammaglobulinemia, good syndrome is hypogammaglobulinemia. Trousseau's sign is superficial thrombophlebitis. Trousseau syndrome is superficial thrombophlebitis. Non-bacterial thrombotic merantic, sterile. Okay, this is the endocarditis, sterile. It is adenocarcinoma pancreas. Anti-NMDA, ovarian teratoma, and here memory deficit syndrome. Opsoclonus myoclonus syndrome, important. Dancing feet, neuroblastoma, small cell. Opsoclonus myoclonus syndrome is important. Dancing feet, small cell carcinoma, neuroblastoma, paraneoplastic cerebellar degeneration, Purkinje, not very this thing. Anti-Hu, the antibody ka name is important. Anti-Hu is seen in small cell. Gynecologic and this thing is anti-Yo, and Hodgkin's is anti-TR. Anti-Hu is there. Ma'am has mentioned it. Cerebellar degeneration. Gynecologic is anti-Yo, Hodgkin's is anti-TR. Paraneoplastic encephalomyelitis, antibodies against Hu antigen. Lambert-Eaton is presynaptic PQ type. Okay, NMJ, small cell. Everything is small cell. See, ADH and ACTH was also small cell. ADH, ATCH was also small cell. Small cell actually has a lot of paraneoplastic syndromes. And finally, myasthenia gravis, thymoma. Very, very important. X-ray this thing. X-ray question. Thymoma. Next is the rosettes. Just remember this. Homo right is neuroblastoma, medulloblastoma, PNET. Flexner Wintersteiner is retinoblastoma. Flexner Wintersteiner is retinoblastoma, while Homo right rosettes is neuroblastoma. Neuroblastoma, that's what we differentiate from Wilms tumor. Medulloblastoma, PNET. True ependymal rosettes is ependymoma. Perivascular pseudo-rosettes. All of the above, all of the above you'll find it in. And central neurocytomas and glioblastomas, small round cells. It's present in Wilms-Ewing's lymphoma. Okay, small round cells, Wilms-Ewing's lymphoma, primary neuroectodermal tumor, neuroblastoma, rhabdomyosarcoma, retinoblastoma. All this is small round cells, very important. Well PNR. Okay, Wilms-Ewing's lymphoma, PNR, primary neuroectodermal tumor, primary NET, neuroblastoma, rhabdomyosarcoma, retinoblastoma, carotid body tumor, paraganglioma. Done. Okay, next we'll do immunology, and we'll finish the this thing. We'll do as much neuro tomorrow. It'll get over. Okay, neuro will finish tomorrow, and then maybe we'll start with another system. We'll finish 2 systems, I mean, tomorrow. Quite a lot. Okay, good night.